Hi, I'm Tom Marino. At Cone Resnick, we believe that all citizens need to be informed about the issues that affect their daily lives. That's why we're proud to support the programming produced by Caucus Educational Corporation and their partners in public television.
Nurse Practitioners in the New World of Healthcare, next on Caucus, New Jersey.
Funding for this edition of Caucus, New Jersey has been provided by Holy Name Medical Center in Teaneck, New Jersey. Healing begins here. New Jersey Manufacturers Insurance Group, auto insurance, homeowners insurance, and banking under the principle of stewardship. Wells Fargo, the law firm of Gibbons PC, Johnson & Johnson, and by New Jersey Natural Gas, proud to support education in our communities. Promotional support provided by NJ Biz, All Business, All New Jersey, The Star Ledger, and NJ.com, Everything Jersey, and by New Jersey Monthly, the magazine of the Garden State, available at newsstands.
Welcome to Caucus, New Jersey. I'm Steve Adubato. Now, the Affordable Care Act will be set into motion in January 2014. Nurse practitioners are expected to make a huge impact on this new world of healthcare. Here in the studio to discuss this changing landscape, we have Dr. Kathleen Scura, who is Associate Professor of Nursing at Fairleigh Dickinson University, Dr. Judith Kutzleb, who is Vice President of Advanced Practice Professionals at Holy Name Medical Center, Dr. Patrick Beaty, Chief Medical Officer of the Metropolitan Family Health Network in Jersey City, and finally, Denis Tarrant is CEO of Manhattan House Calls. Thank you all for joining us very much.
Thank you.
The changing face of healthcare. We're doing this program in the fall of 2013. The world's going to change in 2014. Nurse practitioners, they've always been important. Are they going to become that much more important with this new law?
Yes.
Describe it. By the way, what is a nurse practitioner?
A nurse practitioner is an academically prepared with a Master's of Science in Nursing degree who has advanced skills in assessment, able to diagnose. They have the underlying advanced pathophysiology, and they know the disease process management. So they can treat, they can manage, they can assess, they can diagnose. It's kind of it's a big world of acronyms: nurse practitioner, advanced practice nurse. They're one and the same.
Are they?
Yeah, pretty much, yeah.
Okay.
Here in New Jersey,
but they're going to be
are.
more important after the new law is put into effect.
Because we're autonomous. We are autonomous practitioners who have our own license, our own DEA, and
DEA?
Yeah, for controlled drug
the ability to
substance.
What are you, just bringing more acronyms that we don't understand?
Sorry, our DEA. We have our own licenses to prescribe, so we are autonomous practitioners able to provide primary care.
Got it. Talk about this. Now, talk about your organization, Doctor.
Well, I work for a community health center, a federally qualified health center in Jersey City. We treat very underinsured, very uninsured patients. We have
Sorry for interrupting. Are nurse practitioners a key part of, an integral part of your operation?
Yes. The reason being is I think one of the things that we recognized early on that there was a decline in the number of primary care providers coming out of medical school.
We don't have enough primary care physicians.
Absolutely.
Got it.
And the prospects of more coming out are
not going to get better.
No better.
So as we continue to struggle to have the number of primary care physicians that we need, and it's not going to change anytime soon, probably get worse, the need for nurse practitioners with the skill set becomes greater.
Absolutely. What happens is the primary care physicians that are in practice right now are overwhelmed, to say the least. And this new Affordable Care Act will overwhelm them even further.
Otherwise known as Obamacare. Jump in, go.
Sure.
Describe your organization, by the way.
Sure. I run Manhattan House Calls. Essentially,
You actually make house calls?
I do.
Come
on. We made 30,000 over the last 12 years, since 2001. It's something that I started back in 2001. We strive to recreate the medical office in the house. The idea of bricks and mortar is becoming more and more harder to maintain. The idea of being able to pay a mortgage, pay a secretary, pay this, pay that, becomes harder and harder, whereas the highest need patients are right there in their homes, unable to access care. And we've met that need since 2002.
And advanced practice nurses, nurse practitioners
yes,
are a key part of that.
It's the only part, in a sense. Let me back up there.
Go ahead.
It's myself, there's 3 other nurse practitioners. We perform primary care in the house, but we do have home visiting orthopedists, home visiting dentists, home visiting podiatrists, home visiting gastroenterologists. The amount of technology in the home today allows us to do x-rays, EKGs, ultrasounds, all right at the bedside. And when you look in the emergency rooms today, in the modern emergency rooms, 50% of those people don't need to be there had they been seen a week earlier. And the highest cost Medicare population is, which is who I take care of,
right,
largely elderly patients, wind up in the hospital mainly because they had no access to care prior to when it hit the fan.
Question. If someone is seen by a nurse practitioner because, say, there aren't enough primary care physicians, right? Someone's seen by a nurse practitioner, and they potentially avoid going to the emergency room. Are we saving money as a society because the healthcare costs go down?
Well, there's more to taking care of healthcare than just sick people.
Go ahead.
We want to prevent people from getting sick. We want to maintain them at their highest level. And that's something that we thread through our academic programs for nurse practitioners, so that they are very skilled at talking about diet, which is very important in maintaining health. They're very skillful at talking about how they fit into the person's value system. If they have a cultural issue that they're dealing with, they try to work with them, not just to give them a prescription and send them off not knowing what happens.
Right.
So that approach to dealing with healthcare helps the nurse practitioner to do things more than just diagnose a disease and treat a disease. They're looking at the person, and they're looking at where they come from and where they're going to go to, and how can we best keep them healthy.
Doctor, I want to follow up. Go ahead.
I also think we adjuvant the care. I mean, we're great educators, we're coaches, we're mentors. We engage the patient in self-managing disease. And that is an important aspect in health maintenance and disease prevention or progression of an already established disease.
Stay on this for a second. The patient experience. And this is in no way intended to be critical of physicians at all. But is it different in any discernible way, the quality of care and the interaction? Well, those are two different things. Is the interaction / the time spent with a patient any different with a nurse practitioner versus a doctor?
Yes, we spend more time with the patient. That's a documented, researched fact.
Is there any direct correlation between the amount of time spent with a patient and patient outcomes?
I can answer that. There's research that says that when you do head-to-head research, a physician taking care of a patient or a nurse practitioner, that we get the patient's compliance increased, both on their medication.
Compliance.
With medications that you expect them to be on, that we are able to get them to manage their diet better. If they're diabetics, we can keep their blood sugar better under control. Now, those are head-to-head measurements where they've looked at large numbers of patients who are seen by nurse practitioners and physicians, and that's documented in the literature that however you want to say the reason, that's the outcome.
But there are so many complex reasons for that.
It's hard to quantify that.
Why is it hard to quantify?
Here's, you can only quantify emotion and experience so much. It's sort of like trying to diagnose depression. If you have blood pressure, here's the number, here's the pill, it comes down. Blood sugar, here's the blood sugar, here's the pill, it comes down. I'm depressed. Well, okay, how do we quantify that? And there are measurement tools. The same thing with the patient experience. It's very, very hard to quantify. We do go by outcomes data. We do use different scales, different quantifiable scales for patient compliance, for patient happiness with their provider. But it's very difficult to quantify those numbers in a sense.
But a nurse practitioner does or does not. This is the question that keeps floating around in my head as we prepared for the show. Does a nurse practitioner I'm going to use the word replace a physician, or not, or does he or she replace the physician or complement the physician? Go ahead.
I think the word complement is a better word. I mean, one of the big concepts currently going on right now is something called patient-centered medical home.
Patient-centered medical home. Go ahead.
Where a patient comes into a practice, they have a provider, and they have all these other supporting people. A lot of times what happens is the other supporting person to the doctor is the nurse practitioner. The nurse practitioner sometimes can be the leader of that particular team.
Right.
What happens is the patient's experience improves. I mean, you have more than one set of hands on the patient. The nurse practitioner will provide more education, become more responsive to the patient's needs, whereas the doctor will spend more time probably with the more difficult patients who require a lot of hands-on, I call it, spend a lot of time with types of things. There's certain things that doctors, I believe, in this system probably are more of an expert or probably should be the person discussing these things, like end of care decisions. I think more should
end of care, end of life. You mean.
end of life, not end of care. But it might be the end of care. It might be the end of care one.
Go ahead.
Sure. But end of life decisions, a lot of times, I think doctors, by their experience, the number of patients, they're, knowing, for example, if I've taken care of a patient for 13 years and I know at, sometime in the near future, they're no longer going to be around, you need to have this discussion with the family. You need to have the discussion with the patient. What types of things do you want to do? Recently, the state of New Jersey has this form that patients have to complete to detail, for your doctor to complete, to what do you want done? Do you want to be resuscitated? Do you want
sorry for interrupting, but I want to be clear. Only the physician can do that, not the nurse practitioner.
I think the nurse practitioner can start the discussion, but I think ultimately the physician is the person who's going to have to answer a lot of the questions.
Well, here's what I'm getting to, and you raised a very good point, Doctor. I want to understand right now as we do this program, as we approach, we're doing this in the beginning of late September, early October 2013. It'll be seen after that, probably repeat after that. As we do the program right now, what are nurse practitioners legally able to do in the state of New Jersey, and what will they be legally able to do after the Affordable Care Act is implemented, and is that different?
We can prescribe.
Now.
Yes. We can prescribe
Prescribe medication.
Prescribe medication and narcotics, controlled drug
and
substance.
Narcotics.
Yes.
Go ahead.
We can order. We can order.
Translate.
Order testing, order lab work. We can evaluate that. We can order consultations. We can do referrals. We can order and review diagnostic testing. We can admit. We can discharge. We can do the entire admission process.
So let's go the other way.
Notes.
What we
cannot do.
Because that's a long list.
We cannot do in the state of New Jersey.
You can't operate.
We can assist. We can get a license to do a first assist. But the thing is, we cannot order home care for home care nursing services for a patient that we've been following who we know now would benefit from home care visits. We cannot do that, and we cannot order durable medical equipment. So I could not order, pulmonary equipment, oxygen tanks, wheelchairs, and canes.
Why not?
Because Medicare, Medicaid will not accept that
No,
order.
logically, why can't you?
There is no logical reason why we can't.
To give you an example, and I'm not
Yeah.
It's legal.
It's
I
by law.
understand. My question is, should you be able to?
Yes, because
Should
we're
they
following.
be able to?
Yes.
Should they be able to? Of course.
Of course.
Should they be able to?
I think so. I think
so?
I think so. It depends on the equipment. Like I said, for example, if someone has a BiPAP machine, they have sleep apnea, I think it probably is the doctor.
Let me ask you this. If we had the president of the medical society right here, right now, would that representative say, absolutely?
No.
No.
No,
No.
I just want... Would not.
They would not say
Because?
absolutely. I believe because of the fact that their fear of a piece being usurped from their control and their ability to oversee and manage the patient. And I do respect that.
What about if they just had a difference of opinion that they truly believed that the physician must be, and I use this word a lot, the quarterback of that situation, the leader who makes that decision, and that decision cannot be relegated to a nurse practitioner.
Well,
Because
first of all, you're talking about a team.
Got it.
The patient should be the head of the team.
The quarterback. But the patient can't make those decisions. No, I'm wrong?
Well, the patient ultimately has to live with what happens. So the patient needs whoever the healthcare provider is, whether it's physician, nurse practitioner, they need to make the patient understand what the choices are and what the consequences are. And the person who can best do that should be the patient who does whatever
But if the patient says, I really like this nurse practitioner and I want him or her to order this test for me, the law doesn't allow it. Or certain things you just said.
Things.
I don't want to get into the weeds here, but my point is this. I'm curious, now you brought nurse practitioners in a long time ago. You brought nurse practitioners in a long time ago.
Right.
Are most physicians, here's what I'm trying to get at. Are most physicians, colleagues, are they supportive of the idea of having more nurse practitioners do more that right now they can't do?
I will say organized medicine says no.
Well, disorganized medicine says yes? What? What does that mean?
Organized medicine has been
The official word.
the official word,
okay.
AMA, family, essentially the large organizations that have a stake or stakeholders in Trenton, in Washington, have been very verbose, have written papers.
They said no.
Said no.
And the reasoning is?
Because that we don't have enough training.
That's
We
the biggest.
are not safe. That we need to have additional training in order to do X, Y, Z. Now, even though I understand people have different opinions, and that's fine if your opinion is your opinion without being based on quantifiable data. When we as a nurse practitioner society, we have 40, 50, 60, 70 studies showing that we provide high quality, cost-effective care throughout the continuum of a patient's life on multiple levels. And something like as the Institute of Medicine, which is sort of sets the gold standard for medical care, has written a paper to say that nurse practitioners provide this type of care. I want to know a good, solid reason why we shouldn't be allowed to practice to the highest extent of our licensure.
Well, here's my question.
Sure.
And by the way, Paula, help me, what is that name of that agreement again? I want to get a clarification on. What is it called again? The Collaborative Practice Agreement. What is that and why is it significant to the people watching on public television?
In New Jersey, the law is that you have to have a physician, if you're going to prescribe medications, whatever, on your prescription pad, their name.
Hold on, I thought you said that they
But they're not in your practice.
They're not in the practice. The collaborative agreement is for prescriptive authority only, not for diagnosing, not for assessing, not for managing, and not for treating.
And it's not under their license.
It's not under the license.
It's under the nurse practitioner's license.
So he or she is ultimately responsible there.
The nurse practitioner.
Practitioner, not the
Not the
physician.
God, I want to be clear.
Yes.
Well, that depends. That depends on the practice. It depends on where you are.
I don't want to confuse people. Can I?
No, it's not. That's
I'm not saying you are.
No, well, it depends on the practice. For example, the collaborative agreement I have with 2 nurse practitioners goes a little bit beyond that. I mean, it also gives them the ability to consult me on difficult issues.
Is that because you chose to do it that way?
That's the way it's written. That's somewhat of a template that was written. That
In their practice.
in their practice.
In your practice,
Right.
you chose to do it that way because you felt it was the best thing for your patients.
Exactly.
I'm curious about something. I asked the question of you before, what will change with respect to the power and authority of nurse practitioners after the Affordable Care Act, Obamacare, is implemented? What will change?
Hoping some of the laws will change and give us more advantage to practice to the full extent and the scope of our license.
But the law itself does not say, I just want to be clear.
There's no
the
change
law
in the
itself
law.
does not say, you know what, after the Affordable Care Act is implemented, not only will more Americans have access to health care that previously didn't have it, but nurse practitioners will now be able to do certain things that heretofore they weren't able to do because we realize we need them. It doesn't say that. I believe what's being implied here is that nurse practitioners will be needed more than ever before to provide that quality health care for these greater number of Americans who heretofore never had health care. So therefore, de facto, they'll be...
You would assume. You would assume.
But not in the law itself.
The idea that you bring up,
that.
the idea that you bring up is actually a very large problem. That in New Jersey, the state laws that are required in New Jersey are different than New York, are different than Montana,
How
are
could
different
that
than
be?
Florida.
It's a national, it's a federal law that changes health care and access to health care for everyone in the country, but the role of nurse practitioners
Are managed on a state
is managed
level.
on a state-to-state level.
Correct.
Isn't there a
So
disconnect?
if I were to go to Montana, I have full practice authority, hang my shingle, and I practice.
Explain that to people in the tri-state area watching right now.
Sure. For
what
example,
would happen in Montana?
For example, in Montana, which is a full practice authority state, that I believe there's a requirement of maybe 1 or 2 years of collaborative agreement, but in the big picture, that you are fully autonomous to practice without a written practice agreement. That you don't need to have a written practice agreement with a physician in order to practice. To give you an example,
Translation, you go out on your own at some
you
point?
go out on your own after 2 years, on your own.
You cannot do that in New Jersey.
No. For example, I would love to start a house call practice in New Jersey.
You're in New York, though.
I'm in New York. And I started this in New York with its own barriers, and I would love to move my house call practice into New Jersey.
But you don't because?
Because of the regulatory barriers. That I have to pay my collaborating physician a monthly fee. This is not done for free. So when
You want to share your fees?
No.
No? Okay.
But
Proprietary information.
Yeah, sure.
Go
No,
ahead.
but the idea is that we've made over 30,000 house calls in 12 years.
Got it.
A physician
Okay.
hasn't made one.
But I don't want to be trashing physicians
Oh,
here.
but
No.
now what I mean by that, and by no means the physician I work with is fantastic. And we work with collaborative doctors all the time. We work with pediatrists.
But what?
Fantastic.
But what?
But in order for me to practice, I need a written practice agreement that if this physician goes into a multi-specialty practice, and which has happened to me, and the physician is not allowed to be in other agreements or arrangements, my practice ends tomorrow.
Doctor, let me bring you back in here. Denis is saying, look, there's a disconnect with the federal law being implemented, the Affordable Care Act, what's going to be expected of nurse practitioners, and what the law allows practitioners to do right now. Do you agree?
Yes.
Do you see any sense, do you feel any movement in the state in terms of, I mean, we're actually going to do this, some of this programming on Capitol Report. Our program looks at public policy issues in the state because it's in some ways really appropriate there, but I want to touch on it here as well. Do you feel any movement in the Capitol, in the public, that says, hey, we need this, let's move in this direction?
I think it's getting there. Slowly but surely it will get there. And I think an advantage that a nurse practitioner does have to offer is throughout our training, we look holistically at patients and families. And I think that that holistic approach allows us to have that communication and that relationship with patients, and we also enable the patient to get engaged. I think for me, I'm in multiple different settings, and I view a collaborative agreement not as a restrictive aspect to my practice at all. I really truly look at it as a partnership.
Right.
And I am a partner with my collaborating physician. I can refer, I can consult, I am comfortable knowing that there is a lifeline at the other end of my telephone.
Would you be better off without it so that you could, quote, hang out, you put out your shingle and you're on your own? Would you be better off?
Yes and no, because
Okay.
being in private practice, I'll tell you one thing, there is a dire need to have a physician because of that complex patient that their traiing allows them to be able to manage.
You like the way it is? That part of it?
That part of it. Do I like my independence? Absolutely. Am I good as an autonomous practitioner? Yes.
You just hired an additional nurse practitioner. Why?
Because one of the issues that occur is that with our patient volume, it goes up, and it better serves us to have a nurse practitioner for our, what we call low acuity type of visits.
Right.
Basically, someone comes in with an ear problem. They have
Few
a
seconds
sore
left.
throat,
Go ahead.
sore throat or something like that. That would be something that would take up some time for me, but I could probably dedicate that time to someone, the diabetic who's having, problems with their diabetes, people who've had strokes, things of that nature, where, the expertise of the physician probably will be more beneficial to the patient. And so I'm freed up. The nurse practitioner takes care of what I call low acuity visits. Every day with my nurse practitioner, she consults me with maybe 1 to 2 patients that she's sure, but she really wants to hear from me, this is the right thing to do.
Got it. First of all, I promised you we're going to bring you back on our Capital Report program. This is an important topic. We've just scratched the surface. Thank you very much.
Thank you.
The preceding program has been a production of the Caucus Educational Corporation, celebrating 25 years of broadcast excellence, and 13 for WNET, NJTV, and WHYY. Funding for this edition of Caucus, New Jersey has been provided by Holy Name Medical Center in Teaneck, New Jersey, New Jersey Manufacturers Insurance Group, Wells Fargo, the law firm of Gibbons PC, Johnson & Johnson, and by New Jersey Natural Gas. Transportation provided by Airbrook Limousine, serving the Metropolitan New York, New Jersey area. Caucus, New Jersey has been produced in partnership with TriStar Studios. This program has been made possible in part by New Jersey State Nurses Association.
Hi, I'm Daniel Misa, and I'm a staff nurse who works in a hospital. Nurses are educated and prepared to work in many places and areas, like hospitals, clinics, in research, and in the military. As members of the New Jersey State Nurses Association, we thank you for the trust you've given us. Since being included in the Gallup poll in 1999, nurses have been ranked as the most trusted profession every year, except in 2001, when firefighters received top honors. We are proud you have given us that honor.